Yeah, rock and roll.
Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record, and also please remember to fill out and return the program evaluations and give us any ideas you might have in regards to future topics and future speakers. Our speaker today is allergist, immunologist, pundit, and member of the CME committee, Dr. Jay Brown. Dr. Brown attended medical school at the University of Iowa before moving to Chicago and doing his residency and fellowship in allergy immunology at Northwestern. He is a fellow of the American College of Allergy and Immunology and also a fellow of the American College of Chest Physicians, and he has accepted the CME's committee's invitation today to come and update us on sinusitis. And please join me in welcoming Dr. Brown.
Thank you very much, Steve. This is my trivia question for the audience. When is the last time anybody did ground rounds on the subject? It's a trick question. Nobody's ever done ground rounds as far as our available records indicate. And for arguably good reason, it is the proverbial and the literal black box of medicine. Your sinuses are encased in bone. We can't look at them. We can't touch them. We can't examine them very easily. And culturing them with, for those of us who are not ENTs is not really possible. And yet, it's an incredibly common condition. We're talking about these empty spaces in your head. There are four paired sinuses: your frontal sinuses, your maxillary sinuses, and the cheekbones between your eyes, the ethmoid sinuses, and way back tucked under your brain is the sphenoid sinus. And a lot of times we think about the middle ear chamber as the fifth set of sinuses. Like the other sinuses, they have these little tiny drainage pathways into your nose, in this case in the posterior nasal pharynx. And so it's an empty space that pipes into the back of your nose, and for that reason it is fair to say it's at least very analogous, if not actually a sinus. In fact, a lot of our knowledge of bacterial infections derives from our cultures of middle ear chambers, where you can put a needle through an eardrum much more easily than through the bones of the sinuses to figure out what is growing there. You can see, and I'm going to try to use the pointer here instead of the laser for the folks outside. Under here is where your nasolacrimal duct drains. This is where you see the drainage of the middle ear chamber. And under the middle turbinate is where you see the drainage for the sinuses. And here you see a CT scan where a couple of things worth pointing out. This is an uncinate process. Whoops, that was wrong. The uncinate process, this thin piece of bone. When I look at a sinus on a CT scan, I'm reminded a little bit of those placemats they put in front of a child at a chain restaurant where you got to fill out the maze. Can you get from here to there? The object of the game is to aerate your sinuses, and sometimes people have blockages of these passageways. This unit here where you see the middle ear, the maxillary sinus draining underneath that middle turbinate. These ridges are called turbinates, and you got to get air there. Now you can see this fellow has a passageway. It's kind of blocked by this arrow, but I think that's an artifact. And this is the uncinate process. When they do sinus surgery, a lot of times they remove that. More on that in a minute. But you can see how very skinny these passageways are. This is called a Haller cell. It's not a very good example of a Haller cell. It's an ethmoid sinus that's tucked up underneath the orbit. Maxillary and ethmoid sinuses develop first when you're still in the womb. The frontal sinuses start developing at an early age, but they don't really fully develop until you're a teenager, and the sphenoid sinuses are the last to develop. And that's of some significance when you're deciding what kind of a picture you're going to take when you're examining this. And the lining of the sinus, it's pseudostratified columnar epithelium, and the cilia, these little hair-like projections, they kind of look like shag carpet under an electron micrograph, a scanning micrograph. They take me back to the 70s. And that's really important physiologically, is those cilia sweep crap out of your face. And some people are born with defects in those cilia. Some people induce defects in those cilia by virtue of the fact that they're poisoning their faces with cigarette smoke. So a good question is, what are they doing there? Why do we have sinuses? And that's not something anybody can really answer, but for what it's worth, it does increase the surface area of your body in contact with the inspired air, and in doing so, humidifies the air and will heat it. And also your sense of smell derives from those nasal passageways, not really the sinuses, although the sense of smell comes from the olfactory apparatus, which is where the ethmoids are. Our facial expression is a huge part of being a human being. The way we communicate with each other in nonverbal ways. My wife gave grand rounds last week and referenced that TV show that we plowed through, the name of which is escaping me, but it's all about these micro expressions. And so anyway, that's thought to be part of the reason your face has the sinuses. Immunologic sampling, more surface area, more opportunity for the immune system to get a whiff of what's going on. It's involved in phonation and the resonance, kind of like a guitar has a big empty box, so too are our voices more apt to project with the resonance of our faces. And it sort of serves as a crumple zone for, if somebody's going to punch you in the face. So if you're an unwanted participant in, for example, a political rally, and the speaker, for example, suggests that somebody beat the crap out of you, probably best you take it in your sinuses than like directly in your brain. The problem of sinusitis, as I mentioned a moment ago, is a big deal. A lot of us get this problem. 12 to 16%, about 1 in 7 adults will have this. A little more women than men, although that's not entirely seen throughout all the different epidemiologic work on the subject. It occurs at all ages. We'll see toddlers, we'll see old people, but middle-aged people, let's hear it for the middle-aged people. Middle-aged people get most of this, a little more in the South than the rest of the country. And again, that becomes an issue with how you go about reporting this and who's calling what. So how you code the thing. Here in Iowa, I'd like to think we are a little stingier with the antibiotic use, and perhaps we're coding less sinusitis when people show up with a cold. More on that in a minute. This is an expensive problem. So before we start talking about missed days of work, just the doctor visits and the studies, we're talking $3.4 billion for acute sinusitis. That doesn't include the surgeries. That doesn't include the C. diff infections that resulted from all the antibiotics and what have you. And chronic sinusitis, also a very expensive item. So let's talk, I believe, next on some definitions. Sinusitis is not a term that we use as routinely as we once did. Sinusitis implies inflammation of your sinuses, and almost always, if you have a sinus infection, be it viral, bacterial, what have you, inflammation of your sinus, you also have the same inflammation in the nose. And these definitions of time frame are important. Acute sinusitis, 4 weeks, chronic, 12 weeks, and then subacute somewhere in the middle. And then there's the dreaded recurrent acute sinusitis, 3 episodes a year. And we also categorize this based on the cause of the problem. So when a doctor says sinusitis, or a patient tells me I have a sinusitis, I read into that, oh, you think you have a bacterial infection, you think you need an antibiotic. And I think historically that is what's been meant by that. But understand, of course, viral infections, by far the most common cause of somebody showing up with a bunch of snot. It's viral. Fungal infections can give people a bunch of yicky snot. There's allergic fungal sinusitis, and more on all that in a minute. The differential on this is pretty substantial, but I really want to dwell on the importance of distinguishing. We have Dr. Kitchell in the audience, I saw. Facial pain can be a headache, and it's fair to say that a lot of these people who show up with pain in their face, their sinuses are fine. More on that in a minute, but it's really important to take a careful headache history. And a lot of the people I see miserable with their facial pain, if you if you take the full headache history and talk about intensity and duration and associated factors like noise and light bothering them, nausea and vomiting being associated with that, you find out if the headache pain is throbbing, you'll find a lot of these people, they haven't got a sinus infection at all. They have a headache pain that happens to be in their face, but it is a headache pain and often best treated with the same measures we'd use for pain in their head if it were in their forehead or in their parietal area or what have you. There's a phenomenon called a midfacial segmental pain syndrome, which is, I think, a pretty crummy term. Now they post these things online. I hope I'm not insulting the guy who came up with that, but you'll never know. I'll find a tricyclic antidepressant, for example, to be potentially very helpful for this. A lot of these people that have bad ear pain, but even sometimes facial pain, TMJ is on the differential. Dental pain, unfortunately, the nerve roots that innervate your sinuses, the maxillary sinuses, also innervate your teeth. And I had a lady once just utterly convinced her teeth were the source of all of her problem. Had a dentist take out all of her teeth, and it was sinusitis. It was a fairly horrible scenario. Neuralgias, can be miserable, and it's facial pain, herpes zoster. These are all things that should be going through your mind. Chronic sinusitis, when you're talking to people, find out how long they've been miserable with this. Invasive fungal sinusitis, mercifully, is a pretty rare thing in immunocompromised people. More on that. Oh my gosh, do I have a lot of slides. Allergic fungal sinusitis, more on that later. Allergic rhinitis, that's what I do for a living. A good part of what I do for a living. A lot of these people with ongoing drippy noses, they haven't got allergies, and we approach them in a very similar fashion. Fungus balls, more on that later. So let's talk about the most common reason a patient shows up in your office with a bunch of snot and they're miserable, and I think it's really important that you acknowledge their misery, because if you simply say, oh, well, there's nothing to do for you, they're reading into that you don't really care about me, and they're not feeling the love. And I think it's important that you acknowledge, this is a really miserable thing. So your nose and eyes get infected within 24 hours of exposure. The viruses that drive this, rhinovirus, influenza virus, come on, clicker, parainfluenza virus, RSV, coronavirus, adenoviruses are the usual suspects. You'll never know. Well, you might know with the influenza, and you might know with the RSV, but it's not going to radically alter your management. So this is an interesting piece of work done out of Canada. I'm going to gloss through this pretty quickly because, in short, the purulent snot, the yicky snot, the pain on one side more than the other, the pain going into the teeth, the double bump where you're yicky and then you're a little better and you're a little yicky, and pain with change in head position. These things are modestly helpful, but not that helpful. And so I waded into the murk of positive ratio, negative ratio. I'm not going to bore you with too much of that, but I will. Oh, and maxillary tenderness, the thumping on the face. I've always contended that distinguishes the people that came with an agenda of wanting an antibiotic versus not. I don't like to be punched in the face or tapped in the face even, whether I'm at a political rally or not. And I would tell you that it's really not predictive of who needs an antibiotic and who doesn't. But, I wish it hadn't done this. I want to put in red one of these parameters. There it is. Yicky snot, when you look up the nose, actually is of some more than average value to you. And I think that will motivate me a little bit in making this delicate decision as to who gets what. That is to say, whether or not people get an antibiotic. So it could be, and this is from UpToDate, 2% of acute sinusitis is due to a bacterial infection. Geez, that's not much. And I can guarantee you that more than 2% of the people showing up in my office with a bunch of nasty snot for the past however many days, and how many days is a really important parameter. We'll get to that more in a moment. But more than 2% get an antibiotic. But if you actually start poking people with needles, something we don't do, something I don't do, Dr. Hermsen might, but not very often, you'll find bacterial growth in those sinuses in a small minority. Oftentimes that happens on the heels of a viral infection. And the causes, the bacterial causes, the big three are strep, pneumonia, Haemophilus, and Moraxella. And there's more than one bug in a number of these people. This is, we get very frequently patients that are not responsive to amoxicillin or a penicillin derivative by itself. And the mechanism of resistance in strep is not a beta-lactamase, which is why you see these slash non-amoxicillin sensitive. That's oftentimes a majority of these patients. Haemophilus is not going to respond very well to penicillin derivative, and Moraxella almost always is going to be resistant. So here is the pie graph of what bugs do that. You see a little wedge for anaerobes, and there are other flavors of strep that will do this, and then the also-rans. Staph, the little green wedge, 3%. It's mostly strep and Haemophilus with an occasional Moraxella. Moraxella a lot more common in the smokers. So this is the most important slide I'm going to show you guys. How do you decide who gets what? Well, good news for everybody. You no longer have to. I throw the Infectious Disease Society of America under the bus all day long with these patients and saying, look, Bob, not my fault. I am not giving you an antibiotic. These clever doctors have decided who gets what. And here's a fun statistic for you. If you treat all these people showing up to the office with their snot with an antibiotic, you will help precisely 1 in, well, I shouldn't say precisely, but 1 in 15 is the number you get thrown out that I saw in Journal Watch years ago. Maybe a little more benefit for the youngsters, but 1 in 15. And I would also tell you that an important thing to bear in mind is that those people who responded, that may not be the core of the problem. Bacteria may be complicating an already existing bad situation. So, okay, they got some better, but they weren't going to die of overwhelming sepsis, even that 1 in 15 person had you left them alone. If you adhere to these guidelines from the Infectious Disease Society of America, this is circa March of 2012, then you're going to help 1 in 3. So 1 in 3 people, that's still not magic. And I have to guess that if these people update their guidelines, and surely they're going to, we're going to see a better response rate than 1 in 3, because they're going to move the goalposts and make people wait longer for their antibiotics. So what do you need to get an antibiotic from Dr. Brown? From the Infectious Disease Society of America, you need persistent symptoms. You need 10 days of snot. And, that's an important parameter. I'm kind of a wall when it comes to that. Now, there are a couple of exceptions to that. If you are wicked sick, and by wicked sick, I mean you've got a fever of 102 or better, they say for more than 3 days. Now, that seems a little stingy to me. If you come in to my office, and in my office you have snot in your nose and you have a fever of 101, I will probably throw an antibiotic at you. It kind of depends, because these viral infections tend to front load the fevers. But you're not in keeping with these guidelines until that wicked sick person has been febrile to the tune of 102 for 3 days plus. That's a pretty high bar. And I try to word it so that nobody throws anything at me, but how many times have you heard somebody say, well, my temperature is normally 95, but now I'm 98. And, I think how you approach that patient is much more a matter of semantics than science. That doesn't matter. So you have to word that in a way that doesn't make them want to hate on you. And then the other caveat, the other sort of carve out for when can you cheat and use an antibiotic before you hit the magic 10-day mark. And I think the snotty person who was getting through their cold and they're getting better and now they're 102, I think that person deserves serious consideration of the antibiotic. So when do you use Zithromax? Trivia question, short answer, don't use Zithromax. This is not an antibiotic you want to use for this thing. And so I think I was just having a snarky conversation with Dr. Fulton recently, and I think, is it fair to say, Dan, that the consensus was this is not a great drug for snotty people? Yes, he's nodding yes, and that means a lot. So another good question, when do you use clindamycin? Don't use clindamycin. Did I not put an answer there? Almost never. Okay, so there probably are a few situations, and I will use clindamycin when Dr. Arbalou or Dr. Fulton tell me it's time to use clindamycin. I'm real stingy with that stuff. It covers anaerobes real well, but as you may all know, it does not do well with the tummy, and your C. diff incidence is higher. So totally off the subject. I wanted to throw out there while I'm ranting about Zithromax. I saw something in Journal Watch, this is probably 8 years ago, but their mandate was there is no such thing as acute bronchitis. They prefer the term chest cold. They prefer the terms pneumonia. You got one or the other, but that squishy middle where it's like, okay, well, you're too sick to call it a cold and you don't have pneumonia, but here's your antibiotic. That may not apply to the kid with pertussis. If you treat that kid with pertussis, though, you ain't making the kid cough any less. He's still going to have the 100-day cough. What you will do is make the child less contagious, and I think sticking that hideous swab way in the back of their nasopharynx might be a consideration. So when you're going to use an antibiotic, what do you use? It's augmentin. And there are exceptions, and I would tell you that the dosing I use, it kind of depends. If I'm dealing with a great big guy, I might actually augment my augmentin by using the 875's BID with a bonus 500 milligrams of amoxicillin. For the longest time, that predictably got me an angry phone, or not an angry, but a somewhat puzzled and mildly irritated phone call from my friends at the pharmacy saying, Doc, you sent me 2 antibiotics, what are you up to? And the fact is, remember we were talking earlier about pneumococcal resistance. You don't treat that with a clavulenate component of the amoxicillin. That's good for beta-lactamase, but it does nothing for that pneumococcus. You got to just use a lot of amoxicillin. So in kids, 45 milligrams per kilogram. I am on a mission, all of my 8 and 10 and 12-year-olds. I'm like, hey, what's the most important subject in school? And just pushing the math. I was a math major. I've got a sweet spot for that. And it is a huge predictor of how affluent a child's going to end up being. So I'm always in their ear on that. But the funny thing is, I don't ever have to do math. I don't have to add. I don't have to multiply. I don't have to do any of it. If I want to put a kid on augmentin, the computer says, hey, Jay, how about this for a dose? I'm like, well, that sounds good, computer. Thank you very much. So I'm also a big fan of probiotics. And in looking at the literature on this, there's a bunch of literature. I'm also not a big fan of pills where I can get away without them. So at a minimum, I promote yogurt. I think the probiotics may have a role as well in reducing the tummy troubles from the antibiotics. So in a penicillin allergy, this is in your handout. I'm not going to bore you by going through the whole thing, and I have too many slides. So Lori and I are having a contest to see who can run the farthest over the 1 o'clock mark on our talks. So she was last week, in case you missed it. So if the kid's a Barfarama kid, I think sticking them in the butt, that'll teach them with the ceftriaxone is a reasonable thing. But as soon as they're no longer barfing, and this goes for grown-ups who can't keep anything down, be thinking also about the ceftriaxone. However, a person with a horrible facial pain or a headache pain who's barfing, like, do the doctor thing, make sure you're not dealing with some guy who's got a brain tumor or something, right? Or meningitis or what have you. More on that later. Inpatients, geez, you better be flipping sick before we put you in a hospital bed at $3,000 a day or whatever it is these days for your sinus infection. So I don't see these people. My guess is Gene gets called to the bedside here and there, and I'm guessing Dr. Arbalou and Dr. Fulton do. But when they're in the hospital, these are some good choices for you. And if they are sick enough for inpatient treatment, I'm calling in the troops. I want to take pictures. I think a CT scan, probably with contrast and probably the whole head. You're looking not just at the sinuses, but you want to know, what else have you got? More on that in a minute. Vanco might be a thought. Ricardo's, I actually waved these slides under his nose before I came before you. Thank you, Ricardo, for your very thoughtful consideration. He's like, Doc, remember to tell everybody Flagyl is not, metronidazole is not necessary if you've already hit him with the unison of the augmentin. It covers anaerobes very well. Thank you, Ricardo. That's true. So response to treatment, and here are these guidelines. Man, they don't give you much time before you shift gears and jack up the antibiotics. So you're better in 72 hours or they do more. And the reasons people flunk is they've got a resistant organism or there's some complication. I've got slides on that in a minute. I was a hero to some kid I saw on the reservation I worked at as a young man, and I'm looking up his nose, and the kid's got a sponge up his nose. And so he'd been through countless course of antibiotics, look up noses, and I guess this is as good a place as any to mention it. I'm big on the 4 mm tip. They got the little tips, I think, for an infant looking in their ears. But when I look in a kid's nose, I always want the big tip. Look, use the big tip. You get the panoramic view, not the little thing. You've got to scan the whole thing, the nose. And I will tell you, I don't think most of us are looking up noses. And I say that because every time I bring that light up to a patient's face, like a reflex, let's call it Brown's reflex, they open their mouths. So I would tell you, it doesn't cost extra to shove the flashlight up the nose. And you're looking for foreign bodies, you're looking for structural abnormalities. I'm sorry, I'm off the, what are you looking for up the nose? So you're looking for foreign bodies. It's a possible reason why somebody didn't respond. A septum way off to the one side, an immunodeficiency state. So if patients are really refractory and keep getting into trouble, these are some of the labs that I'm interested in. A CBC, big fan of quantitative immunoglobulins. Of all the immunodeficiency states, this is the one you're most apt to stumble into. An IgA deficiency, by far more common than the rest of them, but a low IgG, IgM. And I will warn you that you start doing that on 2-year-olds and 4-year-olds, you're going to get yourself into trouble. It's not to say you shouldn't do it periodically, but there is this delayed maturation of the immune system in some kids that could be thought of as a normal variant, hypogammaglobulinemia of infancy in early childhood. It's not exactly a disease in my mind. And, we live in Iowa, so it's hard for me to be thinking about HIV very often, but that should be at least somewhere in the back of your mind. So for kids, the youngsters, a Waters view of the sinuses is going to tell you a lot for cheap, and God bless it, you don't have to get on the phone and beg somebody to do your doctor thing. So a quick Waters view can be very instructive, and our radiologists have, I think, been very helpful in reading these things. I can kind of read them, but I really like their input on that. The CT scan is a much better study. You'll miss sphenoid and posterior ethmoid disease. I once had a scan. Back in the day, scanners were slow, and I used to get a lot of these so-called limited CT scans. They were a little cheaper. I don't think there's any price break anymore. I'm not sure on that, but you're in and out of the scanner pretty quick, and so there's less radiation. But back in the day, I'd do a lot of these limited sinus CT scans before the insurance companies were so aggressive in this prior authorization thing. And I found a patient, having had a conversation earlier with one of the radiologists who has since retired, and my perspective was at least my training had been, you miss a lot of posterior ethmoid and sphenoid disease if you just get plain films. So lo and behold, I got a lady with bad ethmoid sphenoid disease, but nothing in the maxillaries or frontal. And I called this radiologist and said, just for kicks, would you mind taking a picture of plain films and see if you can tell anything? It was his contention that he could, and he couldn't. So, I don't know. I like the CT scan. You can look for other pathologic, anatomy issues that might be of keen interest to our friend Dr. Hermson. You can see the osteomeatal units and play the placemat game. Can you get to the air? Hyler cells, those little ethmoids under the eyeball, will squish that osteomeatal unit, making the aeration more difficult. Some complications like bony erosions and subperiosteal abscesses, these people are goofed up. So what do I like for this? Oh my God, this is 2 talks in 1 hour. We're not going to get through the whole show, guys. Saline irrigation, I love this. This goes back to biblical times when Jesus was walking around. People were doing this stuff. You can't hardly kill somebody with it. And I think, it's gaining ever broader acceptance in the population. And everybody does this. I mean, the allergists, the ENTs, the ID people, I think we all like this. Lots of studies showing benefit, lots of different ways to do it. And one of my pet peeves is that we don't have enough head-to-head comparisons of this way versus that way. There is one good one that I'm going to share with you, and I should also mention that 2 people in Oklahoma City died from putting amoeba in their face because they were using tap water. So a couple of caveats: no tap water, purified, distilled, or boiled water, and no iodine. The salt should be iodine-free. Iodine slows down the cilia, so that's bad. Enrollment criteria in this study, you can see here, you needed nasty snot for at least a month. You needed to be between 3 and 16 and have goofed up plain films of your sinuses. And here you see the pre-treatment groups being very similar, but here's the punchline. And I'm going to my mouse. So the snot scores were about the same for both groups. The coughing only got better with that strong salt water. But look at this. The X-ray scores went from 8.06 down to 2.66 for the kids who had the strong stuff. And I'll quote those numbers to patients, and I'll talk this up, because you know what? This stuff sucks. This burns and stings, and it's an unpleasant experience. And I would argue that without a hard sell, your patients aren't going to do it. So here's the recipe, and that is in your handout. 1 milliliter. So a good question is, well, what's the right volume? And other good questions, what's the right temperature? What's the right method? I mean, a squeeze bottle. Do you want to use a syringe like I give out every day? Patients like leaving the office with free stuff, so I give them a syringe. It costs me 3 cents. So that's what I do. And, you know, the over-the-counter stuff, the Neomed products, I'm good with them. I think they're better than nothing. They actually make a strong saltwater cocktail. And here you see this lady doing this thing, and I'm much bigger on seeing to it that people do this as opposed to doing it a specific way. So I'll never, you know, be in somebody's grill over, you know, oh, no, you're not doing it the way I told you to. So analgesics, there's formal data on this. I'm a big NSAID guy for these people who are miserable with their facial pain. A few quick thoughts on steroid sprays, and this is me with too much time on my hands, but I made a bunch of slides I'm going to gloss over. We want a drug that's going to stick to its receptor, and they're quite variant in terms of their potency. They use dexamethasone as a 1 mark here on this potency scale. They have different micrograms per spray, and here you see how they compare in terms of how much steroid effect you get with the different drugs per spray. And I would mention that I had a study that I used in a slide I used in a talk many, many years ago that was trapped in an old dead computer, where it looked at different doses, and it turned out that no Nasonex, 12.5 micrograms, which is a quarter spray, did about what 25 did, which did exactly what 50 and 100 did. So I think there's a real diminishing return on the steroids. I'm usually a 1 spray a day guy, different for the polyp people. So other considerations, particle size matters. And it could be that for the patient with really bad disease, the QVAR, the aerosol, is a little better, although there certainly are not studies that, to my satisfaction, demonstrate that. And some people actually do this budesonide, the ampule that we use for the asthma kids, put in one of those squeeze bottles, and I think that is justifiable. I've had some good clinical responses to it, so do with that what you will. It looks like you got to treat 15 people with a steroid up the nose to get benefit for one of them. I don't use the decongestants much, the Sudafed stuff, all sorts of side effects. If patients have stumbled into them, I'll go through the side effects, and I have kept more than a patient or two away from our friends in urology by going, dude, you're up 3 times at night because you're on the Sudafed, get rid of the Sudafed. Or, you know, the lady that says she's, you know, not able to sleep, and I'm like, well, no, you're taking a bunch of Sudafed, so be aware of that. The topical decongestants, talking about Afrin, neosynephrine, all that junk, that stuff is evil. And it's evil because it's so addictive. So when I see people on my examining table and they're talking to me like this, I'm like, so Bob, tell me the drug my nose, I can't breathe out my nose. And the guy's got one of 2 things, almost without variation. He's got nasal polyps up his nose, more on that in a minute, or the guy has discovered Afrin. And some of these people, as you discuss this with them, will produce the generic bottle of Afrin out of their pocket. Oftentimes the label is all tattered because they've been carrying the thing with them everywhere they go. And they're like every 2 hours. One of my mentors at Northwestern had a newspaper clipping about some lady who's reaching under her pillow to use her Afrin in the middle of the night. That's how desperate these people get, except the same lady was a little paranoid about intruders or something and also kept a handgun, shot her head off. So that's weird, and I'm sorry for that. So antihistamines, not really for this. For allergic patients, maybe. Mucolytics, the guaifenesin stuff, it's not going to hurt anything. And remember, part of the agenda in sending your acute nose infection lady, the lady with a cold, the guy with a cold, out of the office, not feeling as though you don't care about them, is to give them things to do. Basically what you're doing is giving them things to do until they naturally get better. But the guaifenesin can be somewhat helpful. And so you can see the studies pretty much, you need to use a lot of it. So you can goof around with 600 twice a day if you want, but 2,400 milligrams a day divided 2 or 3 times a day is really what you're aiming for. A little study showing, yeah, a little more effective, little more response with that stuff than placebo. So, oh, incidentally, the smokers, we got a rant at the smokers, and I just saw this. This was yesterday. I opened up this throwaway I get. I don't know how I ended up with this thing. It's ENT Today, and I'm not an ENT, and I don't play one on TV, but they have interesting stuff to me, so I always give it a quick read through. And this was horrifying to me. So guys, don't let the smoker walk out of your office without getting in their face. You know, it takes a village of healthcare providers to get these people to not smoke, to wear their seatbelts, to not eat crap, and to exercise. And I would argue that that probably ought to be part of everybody's rant. If you show up at the McFarland Clinic, we're going to yell at you for eating crap, not exercising, and smoking. So do with that what you will. Allergy shots, and this is a study. I actually saw this guy present this paper. And you know the old expression, if it's too good to be true, it probably is not true. So this is a problem. I mean, these people, the reason why so many people say, I mean, you know, you young doctors, God bless you, you don't know how good you have it. Because when I came out of training and started explaining to people that, no, we're not going to use an antibiotic for little Bobby who's been sick for 3 days without a fever, the mommies would fold their arms and go, I know my child, and I know that if he doesn't get an antibiotic, that, you know, and it was just torture. And it would take 20 minutes, and she'd still leave mad, or he would leave mad. And now, you know, I want to use an antibiotic on a kid with a bulging red ear, and the mom's like, oh, Dr. Brown, are you sure? And so we've really seen a flip around. But the point is that when you do things to people for a disease that's going to get better, they're going to think you did it. And so I think that's one of the reasons why maybe the allergy shots look so wonderful here. And prospective studies on allergy shots and this process of recurrent or chronic sinus infection are not really available. So why is it doing that? I'm not sure, but hopefully it will stop. Next slide, please. Okay, so functional endoscopic surgery is another option, not for an acute sinusitis. Dr. Hermsen does not want to see your guy who's been snotty for 3 weeks, you know, like keep working on them. But if we're getting into the chronic phase of things, and you get a CT scan, and I think I speak with authority when I tell you that poor woman who was getting her butt kicked, we have one ENT, probably could use 3 or 4, and a very good PA or nurse practitioner, I'm not sure what Sarah is, but the fact is that getting the scan before you send the patient to her would be appreciated. That arrow conveniently points to something nobody cares about. That is a mucocele, and it's of no relevance. What happened there is the patient probably did have an infection along the way. It scarred over that little goblet cell making the snot, and it sort of created a balloon. And back in the days, they'd go in there and pop them. Nobody ever felt better because of it. So in the surgery, and we do a lot of these surgeries in the United States, there's just an infinity of these things done. We don't have prospective randomized trials on this. So in my mind, that doesn't mean it doesn't help. And surgery is not conducive to prospective randomized trials. I mean, you know, talk somebody into having real or fake surgery. There is such a thing. I mean, there's a couple of knee surgery studies where they did real surgery, or they took them to the operating room, they did fake surgery, and then they followed them, and we don't have that for the sinus thing. So if I had snot nonstop and had been through the mill, I want to see Dr. Hermsen, but that's definitely not one of the first things I'm thinking of. So generally, retrospective studies, people seem to think it helps, so do with that what you will. Complications to be aware of. We have the preseptal cellulitis, and something very compelling about both of these children. Anybody want to throw it out there, Dr. Passion? Why are these two children similar in some regard? They're smiling. I've heard John say 100 times, you know, how does he look? Yes, but how does he look? These are smiling children. Preseptal cellulitis certainly deserves to be treated, but you're not having a cow over this. Orbital cellulitis, you're having a cow. These people have goofy eyes. They have proptosis. They're poking out. They're seeing double. These are people that you're not going to give an antibiotic to and send them on their way, obviously. A subperiosteal abscess, another really nasty complication. You can see that bleb of goo on the CT scan. That isn't supposed to be there. So that's a bunch of pus and pushing that poor kid's eyeball out. So other complications, you know, meningitis, intracranial abscess, epidural abscesses, osteomyelitis of the sinus bones, septic cavernous sinus. I hope to go through the rest of my career. I'm not retiring anytime soon, Tiff, but I hope to finish out my time here and never see any of this stuff. But these people are all wicked sick looking. So fungal sinusitis, just a quick couple thoughts on that. Not to be confused with chronic allergic fungal sinusitis. More on that maybe the next time I give the rest of my slides. Fungal colonization, there was a piece of work at Mayo where if you do PCR, you poke people in the cheekbone, like all of them were growing fungus that you could demonstrate by PCR. So, our sinuses are not sterile like they taught me in medical school. They're mostly sterile. I mean, that is to say they're very clean. There isn't much in there, but the fungal sinusitis is when the fungus actually takes up residence and starts raising its family in your tissues. And CT scan can be somewhat helpful, but you really need to biopsy those people. This is a fungus ball. It has a density like metal. So you can see that white spot. I put an arrow to it. That's a patient going to meet Dr. Hermsen, or hopefully her new partner whenever we get one for her. So when are you going to have a cow? Altered vision, the eyeballs are sticking out. They have, grotesque swelling around the eye. They aren't moving their eyeballs, and their face is all goofed up, and they have meningeal signs. And probably the softest of all of this is the worst headache ever. So worst case scenario, Mucor is just a nasty business. I've never seen a case in 22 years here. These are typically immunocompromised people, transplant patients, diabetics, cancer patients. It's rare, fortunately, so I can realistically expect to never see a case. But it does sometimes cluster. So this is a kid who's got a bad black spot on their nose, and this is a poor woman who's had this thing eat away at her face. This is a fungus that eats your face. So there are horrifying pictures, worse than this, where people who have recovered from Mucor, and lots of them don't, but when they do, they're like missing a face. So chronic sinusitis, and again, I'm down to my last 8 minutes, but you need 12 weeks adjunct, objective evidence of mucosal inflammation, purulence, polyps, radiographic evidence, and it's unfortunately a pretty common thing. So when they call house to house automatically with a robocall, the people that don't automatically hang up, 16% of them will say they have it. ICD-9 coding, it's only 2%. Again, middle-aged people, women, a little more than men, very expensive. So the manifestations, you need the snot, and you need the pain and congestion and loss of smell. Kids cough a lot with these things. But in one analysis, looking at 202 patients at an ENT office, consecutive patients, lots of them seem to have it by history. Only 40% had a goofed up CT scan, which is more reason to get a CT scan. A normal CT scan is not a big defeat. Patients will not feel validated and vindicated, so they're like, what do you mean my scan was okay? But break them to them, look, Bob, this is good news. You did not want to have a bunch of goop stuck in your face. And then you can begin thinking about why is the guy complaining about whatever he's got. So types of this, they break it down into 3 categories. I might hit the finish line here. Polyposis, the 25%, allergic fungal sinusitis, where your body isn't infected with a fungus, but it's mounted this obnoxious immune response to it. It's sort of the sinus equivalent of what's known as allergic bronchopulmonary aspergillosis, where your lungs are just, your immune system is going ape on this ubiquitous common fungus. And then, of course, there's the everything else category. So chronic sinus infection, you want to get a good history, because a lot of these people, they haven't got anything wrong with their sinuses. Get that headache history. Find out if they're barfing when their headaches are bad. Put a number on the severity of it. Get a frequency and intensity and all that junk. Ask about using the topical decongestant. Some of these people have discovered Afrin on their own, and the irony is that what they've found to be the only helpful medicine is the thing actually causing their problem. This smoking, get in people's faces on the smoking. I think if they hear it from all of us, we're going to collectively have better results. Big tip for the nose, and look for polyps. And this is what a polyp looks like. They are whitish. I mean, there's some little veiny stuff on that thing, but they are white like China white. And another picture of a polyp, I think, yes. And if they've got that, I would argue that you may be seeing what we call polypoid degeneration of the turbinates, those ridges hanging down from the side. Sometimes they turn all white too when you're really allergic. So I oftentimes will want either Hermsen or one of her partners to stick a flashlight inside somebody's face and say, yeah, structurally this is a three-dimensional polyp or a scan. And the sense of smell for the polyp people almost invariably is gone. They have usually pretty complete anosmia. And most of them are atopic, probably about 2/3, and they have diminished mucociliary clearance. The cystic fibrosis kids, like almost all of them, get polyps, and the other ciliary dysmotility syndromes are famous for polyps. So organic crap can drive that too. Systemic illnesses, Wegener's, these are all things on the differential of chronic sinusitis without polyposis. I think I got a little lost there. This is my you don't have polyps slide. And then a few quick thoughts, and bacteria are often a compounding factor, but again, they're making a bad situation worse. So you're not going to cure them typically with antibiotics. Final thoughts, evaluation, yeah, get the history. I'm repeating myself now. And next slide, please. Yeah, scans, I'm big on scans for these snot monsters. I think trying to talk the insurance company into it. By the time you have radiographically proven chronic sinusitis, I want to know what your immunoglobulins are. I'll just reflexively check IgG, IgM, IgA on those people. I usually want to see a CBC on them, and I might, particularly if I get any abnormalities in the immunoglobulins, I'm doing a whole bunch more. I'm getting flow cytometry. I'm getting specific immune responses to pneumococcus and tetanus. And if I am on my game, I'm asking about risk factors and maybe just checking an HIV test. So there's another variant here where you get the polyps and an aspirin sensitivity, and you have asthma. And those people, oddly, in the hands of an allergist, can be desensitized to aspirin, and that can be very useful. They actually get better. I mean, kids don't try this at home, but if you put a little bit of aspirin, a little more aspirin, starting like 2 milligrams, work your way up. If you don't anaphylax them, which is always unpleasant, you can actually make their polyps and their asthma and their sinuses better with the aspirin. And that would be a Wheeler-Brown-Nassif thing. It doesn't come up much. A lot of these people are atopic, and when they got the polyps, I'm huge on the allergy shots, which have been shown to be quite helpful. And then the allergic fungal sinusitis, I already touched on that. This is a histologic diagnosis to a large extent. You're looking for this allergic mucin. Tom Smith, our former ENT colleague, used to talk about this peanut butter goop. But you still got to look at it under a microscope, so that would be a Jamie and Company thing. They often do have polyps, and they will have unilateral disease. I don't think I mentioned it, but the fungus ball thing almost always is unilateral. And it's dark colored fungi, and it's more in the south, and it might be more in the Mississippi River Basin, or we might have more professors at academic institutions teaching their charges about that in those locations. It's hard to know. So do all the harmless things, the salt water, the steroids. I think the antibiotics, and you may want to go long on those. The macrolides, that gets fuzzy. I would characterize the studies on that as mostly somewhat disappointing. And treating the atopy is important. I mentioned the aspirin desensitization. And I'm lukewarm on all this stuff. The leukotrienes, the oral and topical antifungals, I think have kind of fallen by the wayside. Chemical cautery is nothing I've ever been too impressed with. And I'd say the literature on that is pretty thin. Complementary and alternative medicine stuff, again, not very excited about it. So, my friends in ENT, my friends in infectious disease, and my friends in the allergy department will be happy to try to help you with these people. I think we have some very promising monoclonal antibody treatments for the worst players. This is not something that's going to come up much, but I think more on that later. I saw a patient yesterday got one of these Tuesday. That was yesterday. Boy, time flies. Steroid-impregnated stent in his nose, and he could breathe out of that nostril where Dr. Hermsen had put the thing and not out of the other one. So I'm kind of excited about that. And so smoking is bad for you. Exercise is good for you. Eat healthy. Any questions? Look at I'm at 12:59. Any questions, everybody? Surely somebody has a question. Don't be bashful. Yes, John. I'm supposed to tell you to wait for the microphone. Yeah, don't bother. I'll repeat the question.
As a pediatrician, the first thing I want to say is remember when you're treating kids for acute sinusitis, our criteria is nasal discharge greater than 10 to 14 days associated with a daytime cough and not showing improvement. If you're going to treat thick nasal discharge after 10 to 14 days, you'll be treating most of the kids you see in your office during the winter. It's got to be associated with a daytime cough and not getting better.
Yeah, you saw the cough. It's a very common manifestation
right, exactly.
of this.
And
yeah.
And that's actually kind of what our ID people say.
Okay.
Augmentin, and when you go on the computer, Augmentin, there's an Augmentin ES that has the larger form of amoxicillin in it already, and the dose is 90 milligrams per kilo per day, divided twice a day. And if you give that with a lot of liquids with every single dose, I'm a big fan of Augmentin. And I tell my parents that, and I have less and less kids that tend to not finish out treatment because of that, though I like probiotics.
Yeah.
And then the final thing is that recipe that Dr. Brown has, I actually have in my office a whole bunch of stickers that I had made up. So I just take the sticker off, put it on a prescription pad, explain to them what it is. I'm a big fan of the hypertonic nasal salve.
Yeah, I've had people, they've been through surgery and allergy shots and 18,000 doctors and antibiotics and what have you. And I've had people who've struggled with this for decades say, this is the stuff. Now, that's not exactly science, but, I've got enough gray hairs on my head that I suppose that ought to count for something that my anecdotal experience actually favors this stuff. I sure wish we had more money spent on this. I've lamented the fact that this is not exactly a darling of the people that spend money on medical research. I mean, the monies get spent by the pharmaceutical industry, and there's not a lot of profit to be had from this at this point. All these drugs are generic, and the other monies that get spent are from the government. And it seems to me like if enough people at the Academy Awards are wearing ribbons for a disease, then there go the NIH dollars. And it's I don't know. I've thought about writing a letter to George Clooney. Could you please wear a green ribbon in support of chronic sinusitis? I'm kidding. I'm not really going to do that, but that might be helpful. I mean, it's such a huge expense for us that spending some money on this to derive some real science to hone in on what are the most useful things to tell these people, albeit not profitable things. So thank you for those thoughts, John. Any other thoughts? Dr. Fulton, any tweaking? I gave Dr. Arbalou an opportunity to throw tomatoes at my slides before I presented them.
One other thought I had was I've had some luck with using baby shampoo rinses. The
surfactant thing. Yeah, that's a thing, and it's in that
more
domain.
For chronic sinusitis, but sometimes it seems like that's the trick.
It might be, and it really bums me out that as much money as we spend on this disease process, I think you'd probably acknowledge that we don't have a ton in the way of prospective work on that. But I've had people tell me that has been helpful as well. So. The question was, how do you do that?
How do you do the baby shampoo? I mean, basically, it's sort of caustic, so you basically try and have the patient use as much as they can tolerate. So they dilute it out, and if they can tolerate, a couple drops without a problem, then you have them put a couple more drops until they get to the point where they're like, wow, that's just too much, and then you back off a little bit. But there's not unlike the salt water, there's not like a recipe that I know of because everybody's different.
If you're a real manly man, you just take it straight, Just own it. Any other thoughts? Well, thank you very much for coming.